Hello, today my presentation is on transcatheter mitral valve replacement, Intrepid. Here are my disclosures. So the Intrepid technology has come a long way. You can see it's a 27mm internal trilipid bovine pericardial valve with an outer stent frame that is flexible to conform the native anatomy. Currently, 42 and 48mm size available for the trial, and 54mm are in development. And you can see that now over 350 implants have been performed with 6-year follow-up in the early implants, and now over 50 transfemoral implants have been also performed. You can see that the development is now over almost 10 years since the initial first implant in 2014. Currently, the Apollo trial is enrolling patients for the transfemoral TMVR with the Intrepid system, and soon there will be an European arm starting, and as well as a randomized study in the future. There have been some learnings associated with this first phase of the period with the Intrepid device. Number one, you have to optimize them pre-procedurally with careful screening and medical optimization. And then the second point, because it's transapical, is the LV apex management to minimize the risk of bleeding. In particular, hemostasis is important to our early discharge from the ICU. We also learned that there's a risk of LVOT obstruction with these devices. So the number of screen failure have been quite high. You can see that 45%. And also the analyzing MAC and other conditions have precluded these patients from enrolling into the trial. So how we overcome that is to actually not just look at a static and systolic phase, but also look at a multi-phase evaluation that's been previously published, and also now early systole to determine whether these patients will be able to clear from a neo-LVOT standpoint, because we know physiologically it's not the end systole that matters, but perhaps rather early mid-systole when the cardiac output is the maximum leaving the heart. We also realized that transfemoral TMVR as well as transapical TMVR, you can see that here, there's essentially MR elimination, not just MR reduction. And this is an example of a patient at 5 years old, really has no significant MR to speak of. The Apollo trial, you can see that here has transformed now from initially a randomized control trial against surgery to now a single-arm trial on the left side, but also a MAC cohort up to 300 patients. And you can see that in the MAC patients, they do not have to have moderate severe to severe MR, but moderate MR as long as they can also have mixed mitral stenosis in the presence of MAC. The transfemoral system, you can see that here's a 35 French. It's very similar to what we might see in other transfemoral mitral devices. And you can see that here, the device does not require stiff wire for placement, and it's done with rapid ventricular pacing. And the data is very compelling. Just 15 patients, early in experience, no death, no stroke. Although there's some bleeding complications that have now mostly resolved, but you can see also elimination of MR at 30 days. So in terms of screening, it's very important to quantify the MR and the LV ejection fraction. We now approve for the trial with EF over 25%. And you can see that this is a very quick eyeball method to determine LVOT obstruction risk. The TEE, very similar to MitraClip in terms of the key views, 4-chamber, bicommercial explain to LVOT, bicable explain to reverse 4-chamber, and also aortic valve short access for transeptal anatomy. Because this is a 35 French system, it's critical that we have sufficient transeptal height before undergoing the procedure, and of course, the 3D on false view. Here's some of the examples. You can see this is a transthoracic echo of multiple views, looking at not just the MR quantification, but also the neo-LVOT. You can see that this patient, based on the LV dimensions and geometry, clearly there would not be an LVOT obstruction issue here. This is the TE that I mentioned before, bicommercial explain the LVOT, 3D on false, 4-chamber look at transeptal height, bicable explain reverse 4-chamber to look at the transeptal height and tenting, and also aortic valve short access, look at the tenting here, as you see, explain to a bicable to make sure you're at optimal position. CT screening is critically important. We use EKG gating, just like a TAVR CT, chest, abdomen, pelvis, but also we have a delayed venous phase because it's a transeptal procedure to look at IVC, iliac, and femoral vein anatomy. We also hydrate the patient to ensure that the neo-LVOT is as maximally clear as possible. And we also try to do that to ensure that venous access is adequate. And I can tell you that these patients rarely develop heart failure just because of hydration. So let's just show you a few cases. This is the 1-year-old female, bit heavy, 91 kilos, STS of 3.3% for replacement. No major comorbidities other than paroxysmal AFib, normal creatinine. You can see not really frail. Secondary MR, moderate severe in nature, 37% in ejection fraction. You can see PA pressures, moderate pulmonary hypertension. This is the screening echo. You can see that here. You can see that in the TEE as well. Certainly, there's a lot of MR, 3D on false. You can see that here. The reason why we show this is so that you can see the landmarks for landing in terms of medial side, the lateral side on the mitral annulus, and also the anterior posterior dimension as well. You have to identify these landmarks for your deployment. Of course, transeptal height is key. You can see that here, there's plenty of transeptal height, well over 4 centimeters. And remember, because this is a 35 French system, just like the mitral clip, where you might lose a little bit of support if you flex a bit aggressively to steer, you may also happen the same with this device. So you want to make sure you get maximal posterior in the transeptal access to gain maximal height. This is a CT image. You can see a little bit of posterior MAC, certainly well within the sizing range of 42 millimeter Intrepid. Neo-LVOT, as I mentioned before, not an issue here. And you can see that aortomitral angle 144 is very favorable. Huge atrium, huge ventricle. This is one of the key numbers. Look at 64.5. You need to be at least 49 or 53 millimeters to confirm that you can steer the device safely to cross the annulus to the LV. You can see also here, what we look for is papillary muscle interaction during systole with the device, particularly in patients with primary MR and normal EF, because that can cause very hyperdynamic ventricle motion and potentially cause potential risk of deployment challenges. You can see that here in this patient with the sheath to femoral vein ratio, you ideally want to be at least 1 or less, but certainly this is a reasonable estimate here. And of course, if you hydrate these patients, typically they get better because of compliance. So the procedure involved right femoral venous cut down at this point, although in the future likely be truly percutaneous. We do put a 5 French sheath on the left side for emergency bypass, a balloon pump, and a left femoral vein, also a 7 French for later ASD closure and temporary venous pacer. We do close our ASD routinely in these patients because of the large ASD. Some people have not done that, but we opt to do that just to eliminate that as a potential confounding factor in post-op management. There are a lot of steps involved here, but these are all the steps you really need in terms of performing this procedure from start to finish. Remember, it is still a relatively complex system because of the large bore device. You can see that how we do the venous setup in access. You basically retract the artery out of the way. You don't need to dissect extensively on the vein. Adventitia is your friend, and you do a plagiated mattress. You can see diamond sutures on the top where you puncture on the vein, and then you have 2 reinforced mattress saw-plated sutures on either side, and we have never had any issue with hemostasis or repair. This is a safe cross-transeptal system. You can see that here. What we're trying to do is a balloon tip guided transeptal to allow you to have exact puncture location to optimize the access for the procedure. After that, we will balloon the septum with a 14 by 40 balloon to allow the sheath to go through. You can see this is an adequate transeptal height of 4.3 centimeters. You can see you need to have at least 2 centimeters in the left atrium in terms of the precursor sheath to be able to withdraw the dilator so you don't trap air. De-airing is extremely important with this in terms of as well as lubricating the dilators because they are not lubricated right now. Once you have the device across, you need to make sure you have 5.5 centimeters in the left atrium to be able to expose the brim and retract the sheath back to the IVC. And you might have to use multiple views on the TE to be able to determine that. Once you are across, you can see the steering is actually relatively straightforward. You initially will have a little bit of aorta hugger or aorta bias, but once you do what we call a tau twist maneuver with inner and the outer catheter, clockwise and counterclockwise in opposite direction, you can see it stands up the device nicely. However, you do want to be prepared to deploy the valve when you expose the brim, because sometimes the device will drop towards the annulus and becomes occlusive, and so you need to be prepared to deploy quickly. You can see medial lateral, posterior anterior, you want to have the landmarks ready to go. And once you're ready, you can see that the rapid pace, deploy, and then you slowly dial down the pacer. And you can see that here on the fluoroscopy, how it releases from an atrial to ventricular direction. After that, you have to remove the bumper, and you can see that here. First, you remove the suture to fully release the valve, and then you remarry the bumper and retrieve this capsule from the ventricle to the atrium. Certainly, this you need to have a very, very slow and methodical retrieval, because there could be a risk of interaction. Sometimes you might even control pace the patient to be able to bring the capsule back to the left atrium. And this is the final fluoroscopic result. You can see that the inner valve is circular, but the outer frame is elliptical, conforming to the native annulus. You can see that we would close the ASD with 16mm Amplatzer from the left groin, and we just close the right groin surgically without any issues. And you can see no PVL, trace MR, no LVOT gradient. You have actually improved a little bit. You can see this is the post-op CT. Certainly no LVOT issue. In fact, the new LVOT is wide open, bigger than predicted. This is the 30-day echo. You can see again, well-functioning valve, no PVL, no MR. EF actually, at least in our eyes, improved. And you can see this 6-month echo, very stable valve. EF consistently, it's better than pre-op. So show you a couple quick cases extra. So 85-year-old previous CABG, only high surgical risk, patent grafts. You can see these are the echoes. Again, severe MR, wide open new LVOT. On echo, you can see retracted leaflets. You can see that here, no new LVOT issue, 48mm valve. And this is the implantation. Again, you can see that here, circular inner valve, elliptical outer valve. You can see the new LVOT is bigger than predicted, as we typically see in these patients. Another patient, younger patient, 62-year-old male, previous CABG, certainly could have had surgery, but you can see that here with the echo, transthoracic echo, and 48mm valve fits very nicely. We feel that the patient would benefit just from TMVR. You can see that here, very nice implant and the ASD closure. And you can see the new LVOT again is bigger than predicted. Now, this is interesting patient, 76-year-old rheumatic mitral valve. You can see mild MAC, very globular LV. You can see that here, no new LVOT issue again. Straightforward implant, you can see that here. And you can see the new LVOT again is larger than predicted. Finally, a very interesting case, 67-year-old with prior radiation, heart disease, Hodgkin lymphoma, severe MAC, had left main PCI prior to screening. You can see it's a mixed MS-MR picture, very calcified immobile leaflets. You can see the MAC here at horseshoe base, small L neo LVOT, 135. We hydrate the patient, this patient is normal, yeah, but you can see that here, because the MAC and the constraint, you can see the inner valve is a bit more elliptical rather than circular. So initially, you can see that the valve is certainly elliptical. New LVOT is not the issue here. And interestingly, we have the most recent echo showing the patient only a mild MR with further expansion of the stent frame. Patient did extremely well 6 months out now. So next generation of the TMVR, you can see that here, it's a 29 French, more steerable, 3 different sizes. So certainly we would expect to be able to do this percutaneously. So in summary, Intrepid TMVR has now gone from transapical to transfemoral, so it's a simpler, predictable procedure. All 350 global implants have been done with elimination of MR. Sizing new LVOT clearance still a challenge, I think, in terms of increasing the screen acceptance rate. The Apollo trial, as I mentioned before, can enroll any patient with primary, secondary, or even MAC. And I would say standardizing the screening, as you saw earlier, procedural guidance will make this procedure very reproducible and safe. I'd like to thank you very much for your attention.